Understanding the coronary arteries is essential for MRCP, not as pure anatomy, but for predicting ECG changes, conduction abnormalities, and mechanical complications of myocardial infarction. The right coronary artery is particularly important because it supplies the conduction system and the inferior wall of the heart. The right coronary artery arises from the right aortic sinus, also known as the right coronary cusp of the ascending aorta. Functionally, the RCA supplies the right atrium, the right ventricle, part of the inferior wall of the left ventricle, the posterior 1/3 of the interventricular septum in right dominant circulation, the sinoatrial and atrioventricular nodes, depending on coronary dominance. These territories explain why inferior myocardial infarctions are commonly associated with bradycardia and heart block. Several key branches arise from the RCA, each with important exam relevance. The sinoatrial nodal artery supplies the sinoatrial node. In approximately 60% of individuals, it arises from the RCA. In the remaining 40%, it originates from the left circumflex artery. Occlusion of this artery can result in sinus node dysfunction, presenting as sinus bradycardia, sinus pauses, or sinus arrest. The atrioventricular nodal artery supplies the atrioventricular node. In about 85 to 90% of individuals, it arises from the RCA, with the remainder originating from the left circumflex artery. Occlusion leads to atrioventricular conduction abnormalities, including first-degree, second-degree, or complete heart block. This is why inferior myocardial infarction is classically associated with bradycardia and heart block. The right marginal artery arises from the RCA and supplies the right ventricle. Its involvement explains right ventricular infarction in proximal RCA occlusion, which presents with hypotension, raised jugular venous pressure, and clear lung fields. The posterior descending artery, or PDA, is one of the most important branches in MRCP questions. It runs in the posterior interventricular groove toward the apex, supplying the posterior and inferior regions of the heart. The origin of the PDA defines coronary dominance. In right dominant circulation, which occurs in approximately 80 to 85% of individuals, the PDA arises from the RCA. In left dominant circulation, seen in about 5 to 10%, the PDA arises from the left circumflex artery. In codominant circulation, accounting for around 10 to 15%, the PDA receives contributions from both the RCA and the left circumflex artery. The PDA supplies the posterior 1/3 of the interventricular septum, the posterior 2/3 of the ventricular walls, the posteromedial papillary muscle. Occlusion of the PDA can have several critical consequences. In right dominant circulation, it causes an inferior myocardial infarction. Because the posteromedial papillary muscle has a single blood supply, PDA occlusion can result in acute papillary muscle rupture, leading to sudden, severe mitral regurgitation and pulmonary edema. In right dominant anatomy, the PDA lies close to the origin of the atrioventricular nodal artery. Therefore, PDA occlusion may indirectly compromise a V-nodal blood supply, causing atrioventricular block and marked bradycardia. From an MRCP perspective, inferior myocardial infarction due to RCA occlusion should always prompt consideration of bradyarrhythmias, a V-block, right ventricular infarction, acute mitral regurgitation from papillary muscle rupture. MRCP key points. RCA supplies the inferior wall and conduction system. Inferior MI is commonly associated with bradycardia and heart block. SA nodal artery arises from RCA in around 60%. A V nodal artery arises from RCA in around 85 to 90%. PDA origin defines coronary dominance. Most people are right dominant. PDA supplies the posteromedial papillary muscle. Papillary muscle rupture causes acute, severe mitral regurgitation. Proximal RCA occlusion may cause right ventricular infarction. Once the right coronary artery is understood, the next step in MRCP cardiology is the left main coronary artery. Because its occlusion carries the highest mortality, and its branches explain the most common myocardial infarction patterns. The left main coronary artery arises from the left aortic sinus, above the left cusp of the aortic valve in the ascending aorta. It supplies the majority of the left heart, and therefore occlusion is catastrophic. The left main coronary artery divides into two major branches: the left anterior descending artery, or LAD, the left circumflex artery, or LCX. Understanding the territory of each branch allows prediction of ECG changes, mechanical complications, and prognosis. The left circumflex artery runs posterolaterally in the left atrioventricular groove, between the left atrium and left ventricle. Functionally, the LCX supplies the lateral wall of the left ventricle, the posterior wall of the left ventricle, the anterolateral papillary muscle, the sinoatrial node in approximately 40% of people, the atrioventricular node in approximately 10 to 15%, particularly in left-dominant circulation. The LCX gives rise to obtuse marginal branches, which supply the lateral wall of the left ventricle, the posterior descending artery in left-dominant hearts, accounting for around 10 to 15% of individuals. Occlusion of the LCX causes lateral or posterior myocardial infarction. If nodal branches are involved, it may also cause conduction disturbances, including bradycardia or heart block. From an MRCP perspective, remember that the LCX is the dominant artery in left-dominant circulation, and therefore may be responsible for inferior infarction in these patients. The left anterior descending artery runs in the anterior interventricular groove from the base of the heart towards the apex. It supplies the anterior two-thirds of the interventricular septum, the anterior wall of the left ventricle, the apex of the heart, the anterolateral papillary muscle. It also gives rise to diagonal branches, which supply the lateral wall of the left ventricle. Occlusion of the LAD causes an anterior myocardial infarction and is the most common artery involved in MI because it supplies a large proportion of the myocardium. In MRCP exams, a patient with NSTEMI and anterior ECG changes should immediately raise suspicion of LAD involvement. Several high-yield LAD variants and syndromes are frequently tested. Wellens syndrome represents critical stenosis of the proximal LAD. It is characterized by deeply inverted or biphasic T waves in leads V2 and V3 in a pain-free patient. This is a pre-infarction state, and stress testing is contraindicated. A wraparound LAD is an anatomical variant in which the LAD wraps around the apex and supplies part of the inferior wall. In an exam question, this presents as simultaneous ST elevation in anterior leads V1 to V4 and inferior leads 2, 3, and a VF. Another LAD STEMI equivalent is De Winter T waves, characterized by upsloping ST depression with tall, symmetrical T waves in the precordial leads, indicating acute LAD occlusion despite absence of classic ST elevation. Occlusion of the left main coronary artery is known as the widowmaker because it compromises blood supply to both the LAD and LCX territories simultaneously. This causes extensive myocardial infarction with a very high mortality risk. A classic MRCP ECG clue is widespread ST depression, especially with ST elevation in lead AVR and V1. This pattern should immediately raise suspicion of left main coronary artery stenosis or severe triple vessel disease. At this stage, coronary anatomy must be integrated rather than memorized. The RCA supplies the inferior wall and most conduction tissue. The LAD supplies the anterior wall and septum and is most commonly occluded. The LCX supplies the lateral wall and may be dominant. Papillary muscle blood supply explains mechanical complications. The posterior medial papillary muscle has a single blood supply, usually from the PDA, making it vulnerable to rupture after inferior MI. The anterolateral papillary muscle has a dual blood supply from the LAD and LCX, making rupture less common. MRCP key points and exam traps. Left main coronary artery occlusion is the widowmaker. ST elevation in AVR with widespread ST depression suggests left main disease. LAD is the most common artery involved in MI. Anterior ECG changes in NSTEMI strongly suggest LAD involvement. Wellens syndrome indicates critical proximal LAD stenosis. De Winter T waves are a STEMI equivalent. Wraparound LAD causes anterior and inferior ST elevation. LCX may give rise to PDA in left-dominant hearts. Posterior medial papillary muscle rupture causes acute severe mitral regurgitation.